Why don't we go ahead and begin? So, hi, everybody. Thanks for joining. Just to make sure you're in the right Zoom room, this is the Department of Medicine uh, Citywide Medical Grand Rounds, and this is a special Grand Rounds, the Levinson Lecture. I'd like to first start by a land acknowledgement, which is traditional in our department. So we recognize the many indigenous nations that have longstanding relationships with the land on which the University of Toronto works and studies and cares for patients. We acknowledge your presence on the traditional territory of the many indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home of many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgement is only the starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. As I've mentioned, this is a special Department of Medicine Citywide Medical Grand Rounds devoted to the Levinson Lecture. This is named after the former chair of medicine, Wendy Levinson, and it acknowledges and celebrates a faculty member who's had a lifetime, lifelong commitment and contributions to the Department of Medicine and its greater missions in terms of research, education, and clinical care. In that vein, it is my absolute pleasure to introduce this year's Levinson Lecture. It's Dr. David Tang-Wai. Dave has provided us with a biography that is unusually short. I'll give that to you and add some comments. So Dave is a behavioral neurologist and co-director of the UHN Memory Clinic. He's also the departmental division director of neurology for the University of Toronto. He has academic interests in the atypical presentations of Alzheimer's disease, autoimmune encephalitis, and normal pressure hydrocephalus. Uh, Dave is also distinguished by being the inaugural inductee to the Academy of Master Clinicians for the Department of Medicine. He is a former neurology program director and served with great distinction for many years. He is internationally known in terms of his teaching. He oftentimes gives talks at the American Academy of Neurology and has essentially annual workshops that he does that he keeps being brought back by great demand to teach budding neurologists. They also do workshops here at Toronto, which attracts many people throughout North America. Um, Dave also is recognized in terms of his research as far as dementia. Um, and also, as a note, is has become famous for having an uncanny resemblance to the Despicable Me character, the Minion. So you may see some icons here and there scattered throughout his lecture. Dave is a role model to many of us, including myself, and a mentor. He has trained a ton of neurologists, and it is absolutely our delight and our pleasure to have him as a member of our department. Without further ado, I'll turn it over to Dave. Dave, please. Thank you.
Well, thank you, Arno, for the kind introduction and the fact that I do look like a minion. Greatly appreciated with that comment. And there is a minion called Dave who also wears glasses. And yes, I do look exactly like that minion. I'm just gonna share my slides. So thank you everybody for spending your lunchtime with me. And when I was asked to provide or to deliver the Wendy Levinson lecture, obviously I was honored and touched. And then after I hung up the phone, I had a very reaction. And this was my reaction after hanging up the phone. I was starting to freak out. And I'm like, why am I freaking out? What's the big deal? You've given lots of lectures before, but to talk about me, how do I get here? How did I become to this stature Do I feel qualified to present? I really don't like talking about myself in general. I generally push people ahead. And what have I done that I think is relevant? And the most brilliant person that I know is my wife. And she said this to me, and she's repeated this to me on several occasions. And what is unique and what anyone at this university can contribute. And she reminded me, my training was at the Mayo Clinic. You would not be half as successful as I if I stayed at the Mayo Clinic. And those words are very profound. And I had to think, what have I accomplished here? What drives me here? Personally, I'm an immigrant. I love Minions. People who also know me, I actually love Star Trek and I like all things Apple. And I see Gary will chuckle with that one. But I'm first and foremost a clinician teacher. You've heard some of my teaching accomplishments. I've been promoted quickly on basis of sustained elections teaching. I speak nationally and internationally. I don't know how many mentors I have, mentees that I have anymore. I've lost track after 10. I've been an administrator, and in my spare time, I research, and I enjoy doing all of it. And maybe in there, what can I tell people? How have I accomplished this? How do I make this lecture relevant to pretty much the entire Department of Medicine, which I'm thrilled that you're listening? What have I learned here? And really, what can I teach you? What can I impart on everyone? And one of the things is what I had to learn was I had to actually learn how to do this myself. I had some mentorship, but really, what drives the individual? What have I learned easily that I can impart? And here are my learning objectives. One is, how do you break this imposter syndrome, which I clearly was demonstrating? How do you cultivate serendipity to create opportunities for yourself and at the broader nature? And how do you lead without necessarily having a title? Because we all are capable of doing that. I don't have any disclosures. I wish I had some, but I am a unpaid medical advisory committee member for the Hydrocephalus Canada. So first thing is about the imposter syndrome. Likely you all know this, but for those who don't, the imposter syndrome is a feeling, it's a state that you're not quite adequate. And it leads you to be anxious, depressed, have doubt. You can procrastinate. You may think you're not good enough, and you strive to be better. The one thing about imposter syndrome is that it never really goes away. It just gets easier over time. And I have this table which kind of outlines my entire career in a brief way. So going from left to right is the amount of years, and then we're looking at decades. Going from top down on the left-hand side, it's my roles over time. So as a resident clinician, you learn to be really good at your specialty. And then you become better at looking at complex cases. You're discovering new things. You're going to write this all up, and you're going to find other ways to help other clinicians. I started off more of as a researcher when I was a fellow and a resident. Started with case reports. I created some diagnostic criteria. Then you collaborate with other individuals. Then you start to challenge assumptions. You figure out what's missing. And that's the contribution of research. Then oddly, I became a teacher. You're a teacher with other residents, learners. When you're on clinical service, how do you teach medical students? And again, your learners. You participate in academic half day to create lectures. The lectures become specific, and then they become national, provincial through word of mouth. And my final position is actually being one of an administrator, starting as a site director for neurology at UHN, to residency program director, to DDD, and just recently just stepped in as the interim director for the Toronto Dementia Research Alliance. But as each step goes along, that imposter syndrome comes up again. but that means I'm being challenged. You're being challenged. And over time, what happens is as your experience, as your clinical skills, the challenges increases, the imposter syndrome goes less and less and becomes less of an issue as it is today with me. So, what are the things to overcome imposter syndrome? I talk to a lot of people. Arno is included in one of them, my friends, my family. What I say when I mentor individuals is recognize your expertise, which may not be the medical part. Some people have expertise in computer programming, teaching, leading, research, to expand on those individuals and push that forward, to acknowledge your strengths, not one, but plural. Do well enough, which I will admit I'm still working on because I'm a bit of a perfectionist, part of because I'm a neurologist. Find assets and challenges, which is the big thing. Do not challenge yourself to push you to another level. That imposter syndrome comes up again. And practicing mindfulness. So that's the imposter syndrome. Now I'm going to go on to the second point, serendipity. I have a confession to make. When I was in medical school, especially I have a medical student right in front of me right now, I did not understand neuroanatomy. I was trouble in problem-based learning and case-based neurology. I wanted to be an internist. Part of me wanted to be a vascular surgeon because I thought it was cool. And the last thing I thought of was to become a neurologist. I had an affliction. I had a problem. And I was suffering from neurophobia. And neurophobia is the fear of neurosciences and clinical neurology. It's rampant neurophobia. And like any other disorder out there, it has signs and symptoms. And here are the signs and symptoms of neurophobia. About half of medical students point to this as a problem. They're fearful of neurology. There is an inheritance pattern, sporadic, but there's familiar forms of it. It's very rare, but those who are physician parents, like my father was a gynecologist obstetrician, he hated neurology, and that kind of passed it down to me. The symptoms of our intimidation or boredom. Signs, people are confused about neurology and neurosciences, can't localize, can't figure out how things work. And what that leads to is that neurology becomes a mystical profession. The diagnosis for attendance, performance, inability to interpret the neurological exam or administer it. And how do you treat this? Well, to ensure that there is an understanding of what neurology or neuroscience really is. And curiously, I want to focus on the last half of the definition of neurophobia, the inability to, or difficulties to apply that knowledge in basic sciences, which I actually do see my own trainees in the program. So it's not just non-neurologists as well. The problem with neurophobia is that people will not go into the program. And we've actually started to see that in the CARMS matching process. Neurology or neurological disorders is currently the #1 cause of ill health and disability around the world. And that was just published last year. So there is a need to reduce the fear of neurology, neurosciences, and neurophobia. Looking back in medical school, it took one person, a fantastic teacher and mentor, to change my career, to go from medicine, sorry guys, into neurology. And the other thing I'm recognizing over the last 20 plus years of being a teacher and a clinician is that because of complexity, there are more difficulties with clinical skill application, especially in history and exam interpretation, that is becoming, at least in my opinion, more easy, more difficult. I am noticing people are not getting the right history, not asking deep enough the questions to understand what's driving the process as opposed to what is the process. I think a lot of it is related to how complex medical care is, and there's a lot of literature that I've quoted to indicate this. But where can I or you fit in? Where can we intervene? And I thought I can intervene from the lack of knowledge and experience. And how do I maximize the increasing shortage of time to teach and make it as efficient and easy as possible? So I had a mission, and my mission was to combat neurophobia. That my entire career is based on this. So how do you combat neurophobia? Well, we're going to have an intersection between neurology and simplicity. Basically, how do you make neurology and neurosciences as simple and to the point as possible? So I created this concept, neurosimplicity. And no, this is not an oxymoron. You can make neurology simple. These are the examples of neurosimplicity that I've created. Spasticity is like an IKEA drawer. It's that goes very quickly and then you suddenly feel the catch and there's a slow release. Paratonia is a stubborn dog. I don't know how many people have dogs, but if they don't want to walk, they put their feet down, you got to pick them up, you got to drag them. That is paratonia. Similarly, cerebellar functions, reduce it to a simple concept of three functions, three T's: timing, trajectory, and targeting. And cerebellar dysfunction is an abnormality in one, two, or all three of them. That's neurosimplicity. And I've used this concept of neurosimplicity to create serendipity. I deal with dementia, I deal with normal partial hydrocephalus, and how do you make that easy? And how does that create good teaching, collaboration? Even as a DDD, how does that affect me in terms of creating what is required for city grand rounds, for instance? Who can I collaborate to improve knowledge? This is a bit more in detail of how serendipity created or career. It started off with my interest in posterior cortical atrophy, which is what we call the visual variant of Alzheimer's disease. It's Alzheimer's disease, but the primary problem is visual spatial. And as a resident, I screwed up this diagnosis multiple times. And I thought, well, screw this. I have to figure out why. What makes it difficult? And I learned it and I mastered it. How do I make it easy for people? Which then developed into researching diagnostic criteria that's internationally recognized, which then created serendipity. There was an international group. This is 2012, because I still have the calendar on my desk. PCA study group, which then later became this professional PIA group for the Alzheimer's Association. This drive to make things easy, neurosimplicity. How do I make clinicians identify dementias more readily? Which led to the boot camp as my result, which led to an international or a national participation of the boot camp by all the universities in Canada, to having elective students from Canada to come here, which then tells their professors, oh, I should go out there to go talk, which then get me to the guidelines, which gave me into more peer-reviewed papers. All of this is based on one concept, and it's been expanded even further to other disorders where other people have difficulty. Normal partial hydrocephalus, an autoimmune encephalitis. And oddly, I've gone back to research because of these questions that come up, not only from myself, but also from my students, from my learners. So having a focus in your career, you can expand on that one idea and create a massive career process. I'm privileged as a DDD to mentor my faculty, to help them develop career plans, academic practices. And a lot of the time it is trying to figure out what is their core principle. Spending the time, if I do this with medical students, what drives you? Not there's an interest in neurology. It's beyond that. What drives you to narrow it down to a certain focus and then expand from there? This principle has been very important to not only my learners and the faculty, but how to write a CFAR document. How do you write a teaching philosophy? How do you pass through your CPA or CFAR? And how do you write a candidate statement for promotion? I found this on Forbes' website. How do you create serendipity? I didn't know I was doing it at the time, but I actually was doing it. Talking to people, networking, sending up flares. Literally, that was my dementia boot camp. Been in my own event was a boot camp, which led to other things. How do you introduce yourself? What is your click? And ask questions. Understand what's going on. What do people have difficulties with? What do they find easy? And this frames or has framed how I teach, how I do my research, and how I plan for the division. Finally, I'm going a lot faster than I thought I was going to be. Leadership. I found this quote as probably the best quote what leadership is. How to make people better. So I have another confession to make. I never thought I would be a leader. I never thought I would be in this position as DDD. One thing to be the residency program director, but to lead a bigger process never occurred in my wildest dreams. But again, it took my predecessor to push me in that direction, challenged me to take on this role. Wanted to talk a little bit between leadership and management. And I do see and observe that there's a blurring of both of these terms. Management is something I think we all do on service in organizations. It's using the resources that are available to achieve a goal. Leadership is about having a vision. It could be small, it could be large. It's how do you implement it? How do you change people to agree to you and champion for you or with you? These two do overlap. I've seen that over the last 20 years. And to demonstrate that there are ways that you may think that you're not able to affect change, you can, even at a small level, you can. It's how do you do it? How do you approach it? And who do you talk to? People often think leadership starts when you have the title, when you're in a position to have leadership. I don't think so. It doesn't seem to work that way. I think leadership starts early. It starts when you're on service. It starts when you're starting to meet with people. These are small stakes, small groups to exercise your qualities, to practice it. And as you advance in your career, you get good at it, you challenge more, you figure out how to lead it differently. I'm showing this slide again. I apologize for the busyness of this slide. 20 years of looking at this, I find that leadership is a stepwise process. To develop the criteria of various dementias, you're meeting with people locally, internationally, and you're negotiating, you're advocating. To manage people, same idea. You're just expanding that circle, getting larger and larger. What I mean by making it count several times is I could say one thing, I can get a mentorship points from the Royal College. I let people know about that. But it's not what I hear a lot was, am I wasting my time doing this event or this activity? And I would talk to individuals and it's like, well, how do you make it more than once? Can there be another venue? Can there be another positive aspect? And we would strategize. Nothing that we ever do is for nothing. It's how do you position it? How do you market it? How do you sell yourself for it? And one of the things sitting here as the division director, I see a lot of my junior faculty who have accomplished a lot and not certain how to package it, not certain how to sell themselves, not certain that if it's effective, and there is a way to do it. And nothing that people that I've mentored is ever to waste. I mean, never. There's always a point. This I also found on the Harvard Business Review. Qualities to become successful leaders that anyone can practice early. You don't have the title, don't need the title. You want to be authentic and genuine. You want to be curious. And I like to emphasize from the standpoint of external stakeholders. How do they see you? What are they getting at? Analytical prowess, ability to break down complex problems. I have seen that as a must. Come up with new ideas, one that's from teaching to administration to research. Sometimes the standard way is not necessarily the best way, and there's needs a better approach. Adaptability to respond to different dynamics because things change. Can you pivot quickly enough? The one I love is creativity. For me, that's what I needed to develop neurosimplicity. Think beyond the box. I also use this creativity to think beyond complex patients. And I think people who know me, I love complex patients. I like understanding problems and think beyond the box. No one likes ambiguity. And our life is always faced with uncertainty, clinical research, leadership. It's to embrace it, to acknowledge it, and know how to move along when that does occur. Resilience is being able to recognize that you may have to change course. So I link it with more with adaptability and empathy. Can you connect with the person in front of you or with your group? Do you understand what's going on? Do you know what that makes them tick or what's literally frustrating them? And this is from Forbes about the expansion of leadership in terms of as an idea of concentric circles. Self-leadership is obvious. That's us. Team leadership can occur within your small circle, your own clinic, your research team, your clinical service team. Departmental, it gets more research, hospital, university. An organization is much bigger than that. You don't have to be at each point. You can affect change at any single time. You can affect positive influence. I know there's a lot of junior individuals on this call. I got emailed by some of you, thank you, about looking for examples. As an attending, junior attending, or a senior resident, it's one thing what I observe is watching people to tell them to do something as opposed to why are you doing it? You need the why. You need to bring in the allied health to explain the why and how you're going to improve healthcare. As a researcher, it's being how do you convince a skeptical leader, a skeptical um, project manager? When I started as a story on posterior cortical atrophy, I was told early, I'm wasting my time. And I said, well, I still want to study it. The literature isn't all that great. And I had two champions with me to allow me to do that, which then led to the largest clinical series, which led to a diagnostic criteria set. So I stuck to my guns. It's not the first time. Using that to inspire a team, and then how to participate in bigger organizations. As a faculty, since I've got a medical student sitting in front of me, how do you inspire a medical student to be successful? Or a resident, or my junior faculty, to make judgment calls. I've helped individuals create new subspecialties, not because it was needed, because it was needed, like women's neurology. I've helped people change career paths because they needed it. And it's a gamble, but it's a good gamble. I don't need to be the DDD to do that. We prioritize subspecialty development in this division as well, because it's the right thing to do. This is a bit tongue in cheek. Am I for real? How can I do all of this? And it's a question a lot of people ask. Time, and this is all applied to me. Time. Most of my time, I'm an early bird. Most of my time is done in the mornings. My emails, my writing, all my creativity stuff is in the morning. And I pretty much make sure I'm free in the evenings or afternoons, it's on weekends. I don't look at emails at 7 o'clock. Standard rule, my wife would kill me otherwise if I did that. And the other thing is how to reframe. Creativity is a hobby for me. It is not work. And I think, I mean, I get my father is after me with this one. It's like, you're working all the time. I go, I don't call it work. To come up with an idea of a dog as paratonia is creativity. Trust me, I've got other ideas as well, which I'm happy to share on a totally different day. But that is creativity. That is my hobby. And I don't consider it work. It is fun to create. It is even funner, even though that word does not exist in the English language, to create my handouts. It's a work of art. And I think those who've seen my handouts know I'm kind of fringy. It's pretty out there. Now, obviously, not everything that I've talked about can apply to every single individual. But the principles are the same. As you get more experienced, your ease, your imposter syndrome lessens, you become more confident, you're able to tackle on another challenge. And the issue is, how do you tackle the next challenge? Coming back to the beginning, I think we can break or dissolve the imposter syndrome over time. I think, and I know you can cultivate serendipity to create opportunities for yourself. And I can help you with that. And you can definitely lead without the title. I'm reminded this week that 5 years ago was the announcement of the pandemic. And our past 5 years, we've gone through a lot. There are crises in the world, there's issues down south. But I think at the local level, my feeling that each one of us can, if we can inspire one or two people doing what you are really, really good at to change the one person, is what we're here for. That's what I believe. That's what I've done for 20 years. You guys are just great. I've listed this slide as a reminder, not only for myself, but to demonstrate to other people how many people are actually involved in guiding your career and influencing you. Some people think it's only one or two or three people. There's a lot. Each one contributes differently. Each one influences differently. And it is not a shame that I put this slide up. That's not the point. My point is, I am so indebted to all of these individuals to keep me here, to place me in this position. And the biggest influencers I have are my residents and fellows and my students, because they drive all of this. Thank you.
Thank you, Dave. We'll open it up to questions now. If you wish, use the raise hand function if you wish to speak, or you can use the chat function to send questions that I can read out. So please, opening it up. Esther,
Thanks,
please go
Dave.
ahead.
I'm parked somewhere on the side of the road because I could not miss this talk. That's how wonderful of a mentor you are. I have a comment and a question. My first comment is some of the best mentors are some of the best imposters, and imposter syndrome is something very close and dear to my heart. I believe imposter syndrome lives somewhere between mastery and innovation for all of us. Being one of the best imposters that I know, Dave, do you see imposter syndrome being somehow transformed or leveraged in a way to help our learners in the future? How do you see imposter syndrome fitting in the future of medical education?
I think we have to be very transparent that imposter syndrome exists. And you can use it as an advantage or use it as a disadvantage, depending on your point of view. As I said, I am like, thanks, Esther. I am the biggest imposter. I'm sitting here giving a lecture to the entire Department of Medicine. But it's the drive, it's the challenge that forces us to do. It's using the imposter syndrome to do better, to challenge yourself to the next level, and to tap to that knowledge that you can do better. So I use it there, but it also forces me to sit, to talk, to be better. That's how I think we can use imposter syndrome in a productive manner.
Maura, please.
So, David, thank you for that incredible lecture. Really beautifully delivered. And congratulations on all of your accomplishments, including the President's Teaching Award presented yesterday. My question is about, you described the serendipity and um, the different things that you did over time, and also how much you enjoyed it all. And there's the other famous quote, find a job that you love and you'll never work a day in your life, which is how I've found things. And I've also been on all kinds of committees that seemed like they were a waste of time at the time, but then later on, I realized I had learned a lot and made connections and so on. Um, but how in sort of in the era we are in now, how do you recommend that early career people sort of balance the need to spend a lot of time earning a living, work-life balance, and also this ability to um, do all of the things that we want to do in academic medicine?
Of course, you have to ask me a hard question. Um, I think so. Let me address work-life balance first. So work life, I think it fluctuates back and forth. There are times when we're gonna have a lot more work. It'll sacrifice some of the life, but the times where work can be less and we have more time for life. And it's to be able to recognize that you can fluctuate between the two. It does not have to be an absolute 50% one way or the other. Um, I've learned very early in my career to maximize the free time that I'm allotted to do all of this. It's hard to teach that, but it's if I have 2 hours to myself and I have a paper to review, I will do it in one sitting because I've learned how to do it quickly, what I'm looking for. And it's you're building, you're evolving into that process as opposed you have to know it right from the start. So a lot of it is comfort level, a lot of it is that experience again to do it. To be creative is, I could be creative at 2 o'clock in the morning. I get that spark. I got to be up. I'm going to write all this stuff down. Um, and I think you don't have to, I mean, I don't look at it as work all the time. And I think it is a bit of that shift. People are amazed. I see a lot of my students or ex-students, sorry, on this Zoom call, and I appreciate for your support. People are amazed that I will come up with a one of my handouts in a weekend. Not because I call it work. I see how I can deliver this message simply. And for me, it's a creativity outlet. So it is a bit of that reframing. I love what I do. And I think it really has to start with that first principle. Do you love what you do? You will balance out life, but you must love what you do because you're much more efficient and you get things done quickly. Hopefully that answers the question.
Thanks. Others? John Flores, please.
David, thank you very much. There is often in early or mid-career a sense there are greener pastures elsewhere. I'd really like you to go back to your wife's comment and inform, particularly some of the earlier faculty members, as to why you were able to achieve these successes at the University of Toronto and not at the Mayo Clinic or elsewhere.
Um, that list of people that I showed, they're my reason why I am not at the Mayo Clinic or elsewhere for that matter. I had an opportunity to go elsewhere. And it wasn't for my trio of Ron Karen, Barry Goldlist, and Gary Nagley, who helped me kind of figure out what I wanted to do. And if it wasn't for them, they wouldn't let me go for something else. It's being able to network, to meet people, and being able to be appreciated and pushed in that another direction because they think you're capable of doing it. I have spent 8 years at Mayo Clinic. I've had my issues with them. There's a bit of very conservative, but having like-minded individuals to push a career forward, being able to push an individual forward is the best thing you can do as a leader. And having that here at this university, in this department, was very important for me. And yes, there may be greener pastures, but the genesis is here. And once you have that, you don't look back. I have not looked back at all. I still talk to all of them, probably incessantly, but that's why you can succeed here. People may disagree with me, but this is how I feel.
Gary, please.
Thanks, Dave. I really enjoyed the talk. I maybe want to focus more of some comments because I think it's great that you raised some really important things. The notion of imposter syndrome, I think, is so critically important. The insecurities that many of us, when we start in medical school, being surrounded by the best of the best and sort of maybe gone through your earlier schooling, feeling that you're the best of the best, and then being surrounded by the best of the best, and maybe realizing that maybe you're not. But just by bringing it up in an important lecture like this, and maybe as a topic that we discuss more openly with our trainees and junior faculty, would be a really important advance, because I think it's quite prevalent and at times can be quite disabling. So I really appreciated you raising that, and I certainly relate to the question John asked and the discussion, the comment that your wife made. Certainly been my experience. I always encourage people when they have job offers to explore them, because job offers, I think, create a real opportunity for someone to assess where they currently are. And my experience was, every time I followed through on job offers external to the U of T, I came back recognizing the tremendous talent that I was surrounded by, and how that talent really allowed me to succeed so much more than I could have succeeded otherwise. And I think that's certainly one of the real gifts that our university has. But a great talk, and really appreciated you bringing up some of these topic areas that are rarely spoken about, but are important. And we did get the Mayo out of you, David. It was an effort, but we did.
You were very successful, Gary, for that. There is something that all of us can do for our trainees regarding imposter syndrome. And I'm reminded about an incident that occurred to me when I was at Mayo as a resident, where I had seen a patient I thought had a particular disorder, and my staff, several of them, thought I was wrong. And I said, well, what the hell do I know? I'm a third-year resident. You guys are more experienced, but I'm sticking by my guns. And unfortunately, this person passed away at an autopsy, and it was the chair who sent an email to everybody. I was right. And having that acknowledgement to empower the individual, yes, you were okay. You're not an imposter. You were on the right track, can help our trainees. I think we could do that. It will lessen the impact of imposter syndrome.
Dave, there's actually a great comment from Woody in the chat. Is asking if there are studies looking at which groups are affected. And I think most of us know that it tends to be disproportionately among women, and particularly faculty of color or from historically marginalized groups, where it's disproportionately affected by this idea of imposter syndrome. A question that I had thinking of leadership, particularly I think across the board, but we're seeing this, I'm seeing this in education a lot, is that um, leadership these days, particularly in the role of education, particularly in Canada, is really facing great headwinds. We had to deal with the pandemic in terms of deployment and issues like that, accreditation issues, demands from the Royal College, a lot of unfunded mandates, um, a lot of issues in terms of learning climate and the tensions that we have between faculty and learners. So given that, this sounds like a bit of a downer, but how do you see these challenges and how do you see addressing them in today's climate? Thanks.
I knew you were going to ask me that question. And I actually did some background research. So if you look back in medical education, there hasn't been a time where there hasn't been some degree of upheaval at some point in time. Think about the Flexner report, CanMeds 2000, and even as simple as SARS, where there's a question about education of that time. Is it going to be revolutionary? Is it going to be transformative? Are we going to go backwards in time? And every single time, and there's this great article from U of T actually regarding the SARS incident, how well we've bounced back. I look at the current transition as a blip. We're going to go through this. It's to acknowledge both sides have issues, faculty and learners. We both have to get through this. We both will find a common medium, an agreement to move forward. This is not new. It's actually been around for hundreds of years. And I look at this as a blip, as another one that we'll work through it. We'll find the best solution possible until the next one. That's how I look at it. And I don't have all the answers for it, but I know we will get answers for it. We will find solutions.
You're muted, Arno.
I'm sorry. Other questions or comments? I'd just like to remind everybody to complete the evaluation and register your attendance. But on behalf of the department, Dave, congratulations on the Levinson Lecture and your presidential award, which I was totally negligent in mentioning. This is a major, one of the most prestigious awards that can be given at the University of Toronto, and Dave won it for this year. And thank you again for your remarks and your insights. Thanks a lot.
Yeah.
Thank you, everybody. Thanks for attending. Take care. Bye-bye. Thanks.